Kính chào các đồng nghiệp. Hôm nay chúng ta sẽ bước vào cái phiên cuối cùng. Thì trong cái phiên này thì chúng ta sẽ có 4 bài báo cáo. Thì các bạn biết rằng trong cái năm 2023 thì chúng ta có 2 cái thử nghiệm lâm sàng được xem là nổi bật. Đó là thứ nhất, đó là thử nghiệm lâm sàng Interact 3 về điều trị nội khoa đối với các bệnh nhân xuất huyết não. Và cái thử nghiệm lâm sàng thứ hai là nghiên cứu Enrich, phẫu thuật xâm lấn tối thiểu cho những ca xuất huyết não mà với cái thể tích trên 30 ml. Như ta biết rằng hiện nay xuất huyết não trước thời điểm năm 2023 gần như không có bất kỳ chứng cứ gì cho thấy có lợi ích trong cái điều trị xuất huyết não cả. Và khác với nhồi máu não, xuất huyết não mang đến cái kết cục xấu hơn rất nhiều so với cái nhồi máu não. Bởi vì tỷ lệ tử vong xấp xỉ 40-50% và tỷ lệ tàn phế cũng rất là cao. Thì nghiên cứu Interact 3 là một cái thử nghiệm lâm sàng nhằm đánh giá một cái giải pháp điều trị tích cực bao gồm kiểm soát huyết áp, kiểm soát đường huyết và kiểm soát thân nhiệt đối với những ca xuất huyết não. Thì chúng tôi đã rất may mắn được làm việc với giáo sư Coagulation trong cái thử nghiệm này. Như ta biết, như vậy trên cái bài này hồi tháng 5 vừa rồi, giáo sư Coagulation đã trình bày tại cái phiên quan trọng nhất của cái hội nghị đột quỵ châu Âu. Lần này chúng tôi hân hạnh giới thiệu giáo sư Coagulation. The first speaker today is Professor Coagulation. He will present a very important trial. Is Interact 3. Vietnam is one of the country involved in Interact 3. So it's a very important. Please, Professor Coagulation.
Well, thank you for the introduction, Professor Tan, and good morning, everybody. It is so nice to be back here in Vietnam and also to see old colleagues, both here in Vietnam and from different parts of the world. So I'm going to give you an update on the Interact 3 results, and these results were presented at the European Stroke Organisation conference a couple of months ago now. And I just want to elaborate on the results and just give a little bit more background to the study design and the significance of the results. I first of all want to acknowledge that this study would not have been possible with a lot of cooperation, trust and collaboration, particularly between the neurosurgeons at West China Hospital in Chengdu, China, and the George Institute. In fact, the initial funding came from grants to the neurosurgeons at West China Hospital, and that was able to leverage a number of grants, and particularly from the Medical Research Council in the UK, to allow the project to be expanded into a number of low and middle income countries. So this is the publication in the Lancet that if you have not been able to read it, it's open access, it's easy to download, but be careful with the supplementary appendix because that's 180 pages, so that's going to cause a bit of a problem with your printer if you want to download that. So I particularly want to acknowledge my colleague, Professor Yu Chow, who is the Professor of Neurosurgery at West China Hospital. And it was nice for him to join me on stage when we gave the presentation in Europe. And so to do a clinical trial with neurosurgeons is quite a challenge, but also a great opportunity, because one of the problems that we've had with assessing blood pressure control and intracerebral hemorrhage is that we have purposely excluded patients who've had very big hemorrhages or have gone on to surgery because we wanted a very pure patient group because we thought the surgery would interfere with our outcome assessments, and also we thought that blood pressure control is probably like an aspirin. It's not very potent, and so if there's a massive hemorrhage in the brain, blood pressure lowering is probably not going to make much of a difference. So through Professor Yu's networks, most of the participating hospitals, particularly in China, were neurosurgery. So just by way of background then, it's been a very frustrating situation to do research, let alone be involved in clinical practice for intracerebral hemorrhage, because everything that we have is grade 2, probably useful. There's nothing in the guidelines for intracerebral hemorrhage which is level 1, definitely beneficial. And so if you have things that are level 2, it never gives a compelling requirement for clinicians and the hospital services to organise care specifically around that therapy. So no level 1 evidence. We use surgery a lot, and despite the efforts to evaluate surgery in randomised controlled trials, nothing has shown definitely on the primary outcome. There's good evidence it improves survival, but not on functional outcome. And so we've been left with this dilemma, which has created a little bit of reluctance to think about treatments that are going to be helpful. I've spent now almost 20 years evaluating the role of blood pressure in intracerebral hemorrhage because the epidemiology is very strong. Blood pressure goes up as the hemorrhage evolves, and the higher the blood pressure, the worse the outcome. Because you can modify blood pressure, theoretically, if you lower the hemorrhage, if you lower the blood pressure, you can attenuate the hemorrhage and improve outcome. But we haven't definitely shown that. We have shown that it can reduce the bleeding, but that has not translated into a functional outcome. And then, as I've said before, there's been gaps in our knowledge about large hemorrhages, those who've had surgery, and we've never really been able to show that the earlier the treatment, the better the outcome. These are the two big trials that I think you know very well, INTERACT-2 and ATAC-2. There were differences in the way in which blood pressure control was achieved, and that probably in part gave rise to the discrepancy in the outcome on the modified Rankin scale. You know, when we were thinking about doing the analysis for INTERACT-2 10 years ago, 15 years ago, we thought very carefully about using the shift analysis on the modified Rankin scale, but we decided against it because it was not well developed at the time. In hindsight, if we'd done it, we would have had a positive result. Now, we've pulled all of these trials together as part of a meta-analysis undertaken by this collaboration organised by Philip Bath out of Nottingham called BASC. These are all the randomised controlled trials. We used a very liberal inclusion criteria around blood pressure control and the type of intracerebral hemorrhage, so it was very generalisable. You can see here that there's quite a lot of scatter in the point estimates and the size of the evidence with the grey boxes, and overall neutral. Actually, blood pressure control of a modest amount within a few hours after intracerebral hemorrhage didn't make a difference overall on functional outcome. But when you do these meta-analysis, you want to quantify the overall effect, but you also want to look at how the effect varies across important subgroups. And here we did show that there were significant differences. That if you applied a target-based approach, bringing the blood pressure down to a particular level, they did achieve a positive outcome as opposed to just applying a single drug or agent like a nitrate patch. And we did show that there were some differences in the drugs as well, the type of agents. And then in the middle here, you see by time, there was no clear differences between an earlier treatment and outcome. So we do need to do some more research in that regard. This is what I mentioned before, that if you looked at the trials that measured the amount of bleeding in the brain over 24 hours, we did show an effect on reducing that amount of hemorrhage, but it was very small, on average only 1 mil. So we know blood pressure lowering can reduce bleeding in the brain, and there's lots of other evidence to support that, but it's a small amount, and that small amount didn't really translate into a functional outcome. Now this is subgroup analysis from the ATAC2 trial. It's post hoc, and for the first time they did show a signal between starting blood pressure lowering within 2 hours of an intracerebral hemorrhage and clinical outcome. But this is hypothesis generating, but it gives us some encouragement that perhaps starting the blood pressure lowering treatment in the ambulance or as soon as the patient arrives at the emergency department might offer benefit. So with that background, we undertook the INTERACT-3 trial by packaging up blood pressure control with some other variables that together might have a synergistic or additive effect on outcomes. So controlling hypertension, hypoglycemia and pyrexia, and then rapid reversal of warfarin-related anticoagulation. And this was all protocol derived to be commenced within a 6-hour time window of patients presenting with intracerebral hemorrhage. There has been another study in intracerebral hemorrhage, not a randomised controlled trial, but a before and after implementation study in Manchester, UK. And they presented their data by the characteristics of the patient before the intervention, during the implementation of their protocol for blood pressure control, targeting surgery and intensive care management. And then they did a post-implementation follow-up to look at the sustainability of that protocol implementation in service delivery. And lo and behold, with this implementation of a protocol, there was a significant improvement in case fatality, mortality, and there were a number of changes in process of care variables, such as use of blood pressure control, time-based metrics, high dependency care, and reduction in early do not resuscitation orders. So much more active management, quicker management, and less withdrawal of care. So that's a good background. So we designed INTERACT-3 with this stepped wedge cluster protocol. And so compared to normal clinical trials where you randomised individual patients, we randomised hospitals to implement a quality improvement protocol, like an implementation study. And the way this design works, that everybody starts control and then randomly moves over to the implementation of the protocol care bundle, and at the end of the study everybody's in active phase. So it's a sort of a hybrid discovery implementation trial, and it has a lot of advantages that you just include everybody, like a registry. You could include the very sick, the very severe, so reduces selection bias and just makes things move a lot quicker. But you've got to make sure with this sort of design that everything else in the background remains stable, and you particularly don't want to have a COVID pandemic in the middle of it, because that can upset all of the systems of care which you're wanting everything to be stable. And also, the longer the study goes on, you get a lot of fatigue getting into the investigators, which can potentially affect bias. So a lot of advantages, but also a lot of complexities. This was our design, very simple protocol. We had a sample size which we estimated we'd need 110 hospitals, over 8,000 patients. And for the first time in a trial, we assessed patients at 6 months from a central office, because we've recognised that it takes a little bit longer for intracerebral hemorrhage patients to make a full recovery. So this is how we rolled out the study. On the y-axis is all of the individual hospitals. Most of those were in China, and then down the bottom is the hospitals outside of China. Along the x-axis is the time. The red is the control phase, the blue is the intervention phase, and all of us, and we had to roll out the study in these batches. And in the middle here is the COVID pandemic, which affected everything. So you could see that most of the hospitals after the COVID pandemic were outside of China, and most of the hospitals before is inside China. You can see there's variation in the lengths of the intervals between control and intervention. There were interruptions because of COVID pandemic. We had to take all of these factors into account to do the analyses. So this is how you present this type of design. This is what we call a consort patient flow diagram. We had to approach over 200 hospitals to invite them into the study. We ended up recruiting 122 who got randomised into the various sequences of going from control to intervention. These sequences, in terms of the size of the hospitals and patient numbers, were all very balanced. And then out of the hospitals, you present the individual patients, because that's the level of analysis is according to the patient characteristics. So over 7,000 patients were included in our intention to treat analysis, very balanced. Another problem with this particular design, where you include all types of patients like a registry, and many of them in low middle income countries, is you get a lot lost to follow-up. So we had about 10-12% of patients where we had no information on their functional status, which we then also had to include in our analysis through this technique which is called imputation. See, the baseline characteristics are pretty balanced. I would imagine this is very comparable to the type of patients with intracerebral hemorrhage in Vietnam, and I know Vietnam made a very important contribution to the study. It's interesting to note 89% are unskilled. Most patients who have intracerebral hemorrhage are deprived, lower socioeconomic group, farmers, drivers. Intracerebral hemorrhage is a disease of deprivation. Ischemic stroke and myocardial infarction is a disease of affluence. You eat more rich foods and you get hardened atheroma. Intracerebral hemorrhage is a disease of hypertension. Most people had hypertension, and they presented on average with very high blood pressure levels. We had, in the main, these were patients with intracerebral hemorrhage of moderate severity, but you can see from the size of the NIH stroke scale and hematoma volume that there was a very wide distribution of clinical characteristics and volume. So we had a good number of people with mild, moderate and severe disease. Most had blood pressure elevation, and only 30% had hypoglycemia, and only a very small proportion had high fever and abnormal INR levels. Most patients were managed in neurosurgery units, and that was a reflection, as I mentioned before, of the investigators who participated. Most patients got blood pressure lowering because most were hypertensive. Only smaller numbers got the other interventions. So this was driven by blood pressure lowering, but it was part of an overall package of protocol. When you're doing an open trial, it's important to measure the other management strategies that the patients receive. And you can see here that they were balanced between the randomised groups, which is very important. You can see that a lot of people got surgery, assisted ventilation, intensive care unit, and very few had withdrawal of care. And I always say to people, if I have an intracerebral hemorrhage, I'd like to be managed in China, because I know that you get very active care for your disease in everything. You get everything thrown at you for intracerebral hemorrhage, whereas in my country, surgery or the surgeons are very reluctant to do any intervention, and prolonged care and intensive care is unheard of. So these patients got very active care, but importantly, it was balanced between the two groups. These are the level of blood pressure control, blood glucose and temperature, and we had access to this information during the course of the trial, and I must say we were always a bit reluctant that we weren't doing very well in the study because these differences were very small. And as I mentioned before, with our meta-analysis, small differences in blood pressure don't seem to have improved clinical outcome, and so we were a bit depressed during the course of the study that we didn't have a big enough separation of our blood pressure. But lo and behold, the overall result was significant in terms of the distribution of the modified Rankin scale. You can see what's called a common odds ratio. The odds of a bad outcome was less with the care bundle package, and very importantly, it was a reduced mortality as well as better functional outcome. We did a number of sensitivities around this result, various adjustments, various other methods of taking account of all of the complexities of the study over time, and the results were maintained through all of that, so it's a very consistent and robust finding. For the secondary outcomes, there was better quality of life, an earlier hospital discharge, less serious adverse events, and all of those point estimates, what's called odds ratio or mean differences, they're all favouring the care bundle intervention. This is quite interesting. This is the hazard ratio for mortality over the 6 months of follow-up. And you can see here that the distribution of the curves continues after discharge from hospital. So something's happening with the care bundle protocol in hospital that's having an effect after discharge. And maybe that's related to better discharge planning, maybe better long-term blood pressure control. We couldn't find that, but it raises some interesting issues. Now, these are the subgroups which were pre-specified, and the significant differences were in two groups. That was the regions of Brazil, Latin America, as well as Nigeria and Africa, and after COVID. But as I said before, most of the hospitals outside of China happened after COVID. So those two variables are interrelated. And the reason why the differences is that there was better blood pressure separation in regions outside of China, which could explain the greater treatment effect in those areas. So, to summarise, implementation of a care bundle protocol, time and target-based parameters in all patients. So this was part of a policy, not selecting individual patients for a treatment. This is everybody applying it as a system of care. improves functional outcome and mortality. And our estimates of the number needed to treat there was about 35, which is pretty good. Endovascular treatment's probably about 2 or 3. Stroke unit care is about 10 or 12. But a number needed to treat 35 is not too bad. There were fewer serious adverse events, better quality of life, and there was a consistency of the treatment according to age, severity, ethnicity, and we could really not find any alternative explanation for this with this more complicated type of study design. So the implications here is, for the first time, we've got a positive result in intracerebral hemorrhage. There's a surgery trial called ENRICH, which showed a positive result with superficial hemorrhages, which has been announced but not published yet. So things are moving towards positive therapies, managed active care, protocol-based therapy. So the recommendation here in Vietnam, as well as around the world, is that we should be a bit more active now with our ICH patients, treat them with the same urgency and seriousness as ischemic stroke, driven by blood pressure lowering, but this was not primarily blood pressure lowering, it was protocol. So there are various campaigns going on around the world now. In the UK, there's a thing called ABC ICH protocol, which is now extending into Norway and some other Scandinavian countries. Is again trying to work with hospitals to develop systems of care, and there is a call article being developed in the US for what's called Code ICH, again more active care. We're trying to look for ways to get funding and help to support hospitals to implement such a policy. The World Stroke Organisation now, who's trying to develop thrombolysis protocols in sub-Saharan Africa, can now bundle in a care bundle protocol. So now you've got a joint stroke service bundle that you can help to develop services. We are developing obviously some secondary papers to look at. Interact 4 is an ambulance trial which we'll be presenting next year, and maybe there'll be an Interact 5 trial. So a couple of discussion points to think about is that it's the total interventional package that worked, was driven by blood pressure lowering. Maybe it's a little bit like a polypill, synergies and organised care. And there's probably things within the protocol that we can't really measure that made a benefit. The way nurses interact with the patients, the way discharge planning worked, and maybe things around treatment adherence which come out of this type of management strategy that are worthwhile considering. So just a final, for the investigators here in Vietnam who contributed to the study, Dr. Tang and his team, thank you very much for your commitment to the study and all the various, many hundreds of people who've contributed to the study over several years and the funding bodies. Thank you very much for your attention.
Thank you very much, Greg. Any question from audience?
Quý đồng nghiệp nào muốn có câu hỏi thì vui lòng đi ra đứng ở cái khu vực có cái mic.
Because of the using of intravenous there's a lot of infections in acute ICH. Because in clinical practice, we often use intravenous for the level of blood pressure, for example, above 180. But for example, with 150 or 60 or 70, we often use just oral agents. So the question is about in terms of for which level of blood pressure that we should use intravenous Or should we use intravenous for all of the acute ICF patient with blood pressure above 140? Yeah, thank you, Professor.
Yeah, so there's that's a good question, and there's a number of aspects to it. So first of all, we recommend intravenous treatment because you can get the blood pressure under control rapidly, within a half an hour, with most of the drugs. There's only one drug on the market has a very short half-life of a minute, clofidipine, which you could probably get the blood pressure under control within 5 or 10 minutes. But we haven't found any real evidence that the speed of control makes a lot of difference. In fact, maybe if you drop the blood pressure too quickly, maybe 60 or 70 millimeters, so if you drop it down from 250 to 140 within 15 minutes, that's probably a little bit too rapid. But if you can bring the blood pressure down after 30 minutes to an hour intravenously, smoothly, it's good. What's the best drug to use? Everybody asks me. We don't know. It's too complicated. Probably there needs to be another trial to do that, maybe Interact 5. And as soon as you can get the blood pressure under control, the person can swallow, then you can move them over to oral medications. There's only one hesitation. There's been 2 trials that have evaluated nitrates very early in the ambulance, because if you can get blood pressure control in the ambulance, it could benefit those with intracerebral hemorrhage, could benefit ischemic stroke as well. The big trial in the UK called RIGHT-2, they showed that the people who had hemorrhages who were allocated to a nitrate patch had worse outcome. They had more bleeds, they had more had greater deaths and everything. And those trends were comparable in a parallel Dutch trial. In fact, the Data Safety Monitoring Committee stopped the trial early because they saw the harms happening. So there's 2 independent studies that raise some concerns that maybe the nitrates for intracerebral hemorrhage very early on, when there's bleeding occur, may be harmful. Now, I know in the intensive care unit, you know, ICU doctors like to use nitroprusside, but for stroke doctors, we're a little apprehensive about that because, again, nitroprusside's a venodilator. It can raise intracranial pressure, and maybe the nitrate component might have some effect on the bleeding. So maybe there's a little bit of caution with the nitrates. Everything else, though, just get the blood pressure under control with intravenously, half an hour to an hour should be fine.
Yeah. Thank you, Professor.
I would like to ask Professor a question. Would you please tell us in detail about the contribution of each component in the care bundle on the functional outcome?
Yeah. So the size and the location of the intracerebral hemorrhage is very critical. So as you know, you could have quite a large hemorrhage in a superficial location which causes swelling, and maybe the person's pretty drowsy for a while, but they can still recover without any problems with their mobility after a while. But then you could have a small hemorrhage in the internal capsule which can permanently damage the pyramidal pathways, so the person's completely paralysed forever. And as you know, obviously, if you have a small hemorrhage in the brainstem, the person can die because it's very small. So the prediction of outcome is a combination of size and speed of growth and where the location is. There's a number of other parameters around the brain and the pattern of hemorrhage which are very interesting. But how we put all of that information together to come up with something that could help us predict further is probably not quite there yet. So I think all you need to consider at the moment is size and location in vital parts of the brain as being important for prognosis, and then obviously the timing and speed in which that's expanding.
But I would like to ask more detail about when we control blood pressure, glucose, temperature, anticoagulation, and the contribution of each component in on RCH outcome.
Look, there's a particular type of statistical method that we can use called mediation analysis, where we can look at the components of the care bundle that are making the most contribution to the outcome. We haven't done that at the moment. That's our plan to do it. But I think it's a sensible reasoning that if 90% of everybody got blood pressure lowering, that's the major component of driving the outcome. But, you know, hyperglycemia is bad for intracerebral hemorrhage. It probably works on the inflammation and affecting edema and swelling. So I'm a firm believer that controlling the glucose is important. And we know elsewhere that rapid control of the anticoagulation is important. So I think they're all working together. Whether one's more important than the other, I don't think they're all as a package. It's making a difference.
Thank you very much. Because of time, we will move to the next speaker, and maybe if we have time in the end of the session, we will discuss more.